And now we have our final speaker before we have our panel discussion and questions. Mary Politi is our next speaker. Dr. Politi is a health psychologist and an associate professor in the Division of Public Health Services, Department of Surgery at Washington University School of Medicine in St. Louis. Her work aims to help patients and the public understand health information, explore what is important to them when making health decisions, and collaborate to make evidence-informed decisions that meet their needs. Dr. Politi?
Thank you so much for having me, and thank you to everyone for staying towards the very end of the day, but we're looking forward to the discussion. And one of the things I love about a full day of meetings like this is the consistency in everybody's presentations. So we've mentioned a lot about health insurance and access. We've mentioned a lot about user-centered design, trust and providers, and hopefully I'll touch on some of those in a way that talks about cancer patients' financial toxicity. I started doing this work when the Affordable Care Act was first passed, and we had a growing number of people who were accessing health insurance for the first time. We know we're continuing to do a job of covering more people, although we have a long way to go. But now we have a different problem where there's a growing problem of people who are underinsured, who have access to health insurance, but they're on high deductible health plans. And that's what we are able to provide at a lower cost from an insurance perspective. How many people in this room are on a high deductible health plan? I talked to several of you earlier, and we are as well. And there are a dark purple line on the bar on the graph are the people that don't have a health savings account to help offset the costs of some of the out-of-pocket expenses they have on these plans. And they don't have a safety net for providing that when they do need to use care. We also know that choosing a health plan is really complex. This is an example of what our plan looks like. Don't worry about the details. Most people, even in our institution, don't. But it suffers from readability issues. It requires people to do complex numeric information very quickly. There's a lot of unfamiliar concepts: durable medical equipment, spinal manipulation. And there's these bizarre ordering effects. When you put something in alphabetical order and things like chiropractic and spinal manipulation are on page 1, maybe people might use that, but prescription drug coverage, which is used by many, is on one of the last pages of the plan. And when we first started this and we asked people who were previously uninsured what they knew about health insurance, not surprisingly, it had very little meaning to them. Words like deductible were the most confusing to people. This participant told us she thought it meant where you can get a lesser price and deduct down the bill because you can't pay the original cost of your bill. And that was common in her past experience going to sliding scale clinics. They reduce the bill based on what you can pay. And it makes sense based on the word deduct. And then people told us that other contexts outside of health were ways they tried to understand this information. A lot of people talked about car insurance if they had a car. They mentioned if I have to pay $250 before they will fix my car, then the insurance company will pay everything over that. That's closer to deductible in healthcare, but in a car insurance example, you pay each time you may have an accident, whereas in health insurance, you pay for one calendar year. So people were confused and thought maybe you pay each time you go to the doctor, you have to meet your deductible. We also talked a lot throughout the day about trust, and people told us that when they were making health insurance decisions, they cared a lot about who was in their network, particularly if they had bad experiences. This person thought that she had been misdiagnosed because she didn't have health insurance. People weren't taking the time out to really see her. But she had a good experience and wanted to make sure that the doctors she could trust were part of her new insurance network. A lot of us turn to Dr. Google when we're looking for things, and I was pretty surprised when I started trying to figure out if Google had the answer, that I just typed in which health, and health insurance was the first thing that came up. Actually, a lot of people are searching for this information. And how can I pay for health? Or comes up health insurance, insurance in early retirement, health insurance on your own, but there wasn't a simple answer from Google, unfortunately. And we know that particularly patients who have underinsurance, or they don't have enough to pay for care, are avoiding seeking needed health care. They're either postponing care due to cost, sometimes they're going without care altogether. And people with lower health insurance literacy and lower knowledge of health insurance terms and details are more likely to avoid this care. And people with higher financial toxicity are also more likely to avoid care. Financial toxicity originated in the oncology setting to talk about the burden of care costs on patients. And it's not just their ability to pay, but how much it's distressing to them, and how much they worry about whether they can pay their bills, their medical bills. And cancer patients are particularly affected by all of these things. Cancer costs a lot. The medications to treat it cost a lot. The secondary effects cost a lot. And there's confusing new information when you get a diagnosis of cancer that changes the way you use health insurance. Things that were once preventive might become diagnostic, meaning you now have out-of-pocket costs when you didn't have them before. And we know that even people with private insurance that are adequately insured in general, when they have cancer, they suffer from missed appointments, missed procedures, they ration their medication, they report high levels of financial toxicity. Sometimes they report debt of over $10,000. And sometimes they report much lower quality of life when they have higher financial toxicity. It can even be linked to increased mortality from all of these downstream effects. And we know that providers can do something about this if they're willing to have a conversation with patients about costs. 50% of patients say they want to talk about costs. More say they want to talk about costs when they're not worried about being perceived as not taking their care seriously. And cost discussions can lower financial toxicity, both with and without changes to care plans. With changes to care plans, people can switch to a lower cost option, switch to a generic, maybe even change the dose or frequency of interventions. But there are sometimes simpler things that without changing a care plan, people can do to provide free samples, to prescribe something for a 3-month supply instead of a 1-month supply with one copay. And we had patients tell us when we were developing some decision tools to support choice that nobody tells you if you don't ask. Providers aren't offering this information on their own without patients coming to them and saying that they need help. This patient said it was helpful to ask questions. A nurse came back and said, "Wow, I can't believe it's $100. Let me see what I can do." They had some benefit card and it ended up being nothing. They wouldn't have said anything though if I hadn't said, "Wow, that's a lot for a medication for 5 days." I would have just ended up paying it. Nobody tells you if you don't ask. But sometimes people did ask and it couldn't fix the broken system. This patient said it was going to be over $1,000 a month for a medication. I said, "Are you kidding me?" They said they could get the generic, but even the generic was still going to be that much. I said, "This is insane." I did the thing most people would do, try a cheaper drug. That's not a tier 4. Well, it didn't work. So we do need to do more than just talk about it, but sometimes it can help. We also discovered something in the process of doing a study on a different area, not about cost, where we were randomizing people to 2 different decision tools and usual care to talk about early stage breast cancer choices. One had been developed in the UK where cost is not as much of an issue with a uniform health system, and it was text-based. The picture-based tool was developed to be modified and accessible for people with limited literacy, and it did have a section about cost because it was developed here, and it's based on what common questions patients have about their treatments. When we randomized people to this intervention, we found that the picture option grid that had cost information really prompted cost discussions. 67% of cost discussions occurred in the group that were randomized to the picture option grid, and only 33% were in the non-picture option grid groups. But what was interesting is when we started the study, we weren't looking for cost information, but we happened to notice that when we did this fidelity check to the protocol, the surgeons were doing the entire decision aid except the piece about cost. They skipped over that one section of cost discussions. So we realized we needed to do more training. We talked a lot today about provider training, that they wanted to do it, but they didn't know how to say it and talk about it without it coming across as awkward or uncomfortable because they didn't really know each patient's cost situation and insurance situation. But once we did that, we got them to do it more and more. And in the other groups, the patients were the ones that prompted the cost discussions. So moving to this tool that we've developed, we took a lot of this information about what cancer patients told us was confusing about cost information and insurance information. We did a lot of qualitative work and user-centered design to develop a tool. And we just completed an evaluation of a randomized trial of a tool that we've called I Can Pick, which is improving cancer patients' health insurance choices, randomizing them to either the I Can Pick tool or an ACS-developed, Cancer Action Network-developed worksheet. So this is what the tool looks like. It's a web-based tool, but it's also mobile-friendly that you can see on a smartphone. It goes through a lot of terminology and details about insurance, but it also spends a lot of time on deductible, which we know is the hardest for patients to understand. But cancer patients are pretty savvy consumers. They have experience with health insurance. So we actually spent more time talking about the unique factors that are relevant to cancer. Talk with your doctor about the cost of care. So we do more than just provide health insurance literacy education. We also talk about that conversation. What are my labs going to cost? Do you have care that is offered on a sliding scale? What can I do about my insurance to cover this medication? We also have a cost calculator where we help estimate how much an individual is likely to spend on their health insurance and care, given their age, their gender, their type of cancer, and any other health conditions that they're willing to tell us they have. And this is based on medical expenditure panel survey data from the AHRQ, where you can get an estimate on a national level, even personalized to your region, of how much you might spend given these factors. We do this for sample plans, so a sample high deductible plan and a sample PPO plan. We do it for marketplace plans if they're in the marketplace, and then we allow them to enter their own plan details because they may have something specific. They can tell us what's your copay, what's your premium, what's your deductible, and we'll tell you about how much you might spend. And we give it to them overall, and then we also ask them to slide a bar if they want to see what the worst case scenario might be on a high use year or maybe a low use year. We developed this for people who are cancer survivors, but they're within 5 years of diagnosis, so they might have moved to more surveillance rather than active treatment and maybe don't want to go with a higher premium plan if they're not in active treatment at the moment. So we allow them to choose. And we found that when we randomized people to I Can Pick or the attention control, they had much higher health insurance knowledge in the intervention group. They had much more confidence understanding insurance terms and details, items from a health insurance literacy measure. They also described to us this complex trade-off between costs and coverage. They really talked about this decision in a more detailed way than in the usual care condition or intention control. And they all, in the intervention group, told us they prioritized network coverage. They wanted to make sure their cancer doctors and their hospital were in network, particularly when they were in rural communities where this might be far away. And another thing we just found that we don't know if statistically significant is it did reduce their financial toxicity, but we're still looking into that at their 3 to 6 month follow-up. So if I had to think of next steps, we all know insurance choices are difficult, even for people with experience like cancer patients. Costs are a huge burden. Even if you're a savvy consumer, we can't fix some of the issues in our system about how much care costs. And clinicians aren't always talking about this without training and prompts. But when they do, they can help in some way lower patients' out-of-pocket costs. And decision support about health insurance, along with resources to offset some of those costs, can also help patients if we're activating patients. But some system-level changes are still needed to bring this all together. And I want to acknowledge our funders from a lot of this work, the AHRQ, the NIH, the ACS, PCORI, a huge team of people that went into developing this, and take questions, I guess, for as part of the panel.